But I'm going to talk to you about novel biomarkers and risk stratifying patients for cardiovascular risk. And as I put this together, I'm really going to go through our approach, what we've done, and then show you exactly where we're going. As you know, Cleveland HeartLab's goal really is to improve patient outcomes through providing the medical community education and access to novel biomarkers that define patient risk for cardiovascular events, the risk factors that drive the disease process, and the tools to monitor the mitigation of that risk. We proposed, as we looked at this field, which can be quite cumbersome and confusing, that really there's three buckets, if you will, of risk stratification. As Lynn went through, the classic lipid panel really defines your lifelong risk, and I think we all note that if we go by the guidelines and we start screening in the early 20s and somebody has an LDL of 400, they have a lifelong problem. The midterm, really on the order of decades, is better defined by ApoB or advanced lipid testing by whatever measure you prefer. But knowing particle number, knowing number of particles through ApoB, ApoA1 ratio, things of that nature, I think really does define with better granularity what the risk of that patient is over time. But the near-term risk is really defined by inflammatory markers, and that near-term risk is really defined in a matter of years, as best probably demonstrated by the Jupiter trial run by Paul Ridker, looking at folks who, frankly, by current guidelines didn't belong on cholesterol-lowering therapy, but all had high hsCRPs. As you may know, that was a 4 to 5 year planned trial that was stopped in under 2 years due to excess benefit, and that benefit was life. Now we offer, our focus obviously as talked about is inflammatory markers for Cleveland HeartLab, and I think we have some unique and important markers that help define, again, not only who's at risk, but where they are on that risk spectrum of time. And we obviously also offer other lipid testing. Fundamentally, while we talk about inflammatory markers as new, the concept of inflammation and atherosclerosis is incredibly old. It really got its formulation or foundation, if you will, by Russell Ross, the late Russell Ross, when he wrote his response to injury hypothesis in the New England Journal of Medicine in 1976. And what he proposed then was that atherosclerosis is really a two-hit strategy or a phenomena where there's an injury to the vessel wall, which is mostly driven by cholesterol oxidation and cell death. And then there's a response to that injury, and that's inflammation. Now, I would suggest to you that we've spent roughly 30 plus years focusing on the first leg of that hypothesis, which is blocking injury. And we've certainly focused on decreasing cholesterol levels, LDL levels, increasing HDL levels, all in an attempt to decrease injury. And the reality is we've been extraordinarily successful. And, you know, the incidence of ST elevation MI in the last 15 years is down by 60 to 70%. Our patients are clearly doing better. Vascular disease has been completely changed, even in my career. And we're now at a point, and I'm consistently struck by this when I see patients in the coronary intensive care unit, of an era where the majority, I would argue, of our patients, and the literature says 50%, who have myocardial infarctions have normal lipids or controlled lipids. I'm not saying they're naturally normal, but not everyone's out dieting and exercising, at least not in Cleveland and Akron. But the reality is their lipids are where we would want them. And yet they're still having myocardial infarction. And what we recognize at Cleveland HeartLab and through our research is really the fact that if we really want to further improve the outcomes of our patients, we need to start measuring inflammatory biomarkers so that we don't say to Mr. Smith, Mr. Jones, or Mrs. whoever you want, you know, your LDL looks great job, pat them on the back, and we'll see you in 6 months, and they're back in 2 months after their stent and their MI. So that's really the foundation of where we start. And I just want to take you through the path that we've gone on. We're a young company. We're about to approach our third. In November, we'll be 3 years old. And we launched in really January of 2010 our classic Cleveland HeartLab panel. So this is the panel and the vessel wall that many of you, if not all of you, have seen, where we have a 5-marker panel looking at F2 isoprostane, albumin-creatinine ratio in the urine. Both of those are urinary tests. An hsCRP, and a myeloperoxidase and an LPPLA2 or a plaque test. And the concept that we put forth, again, as I mentioned earlier, is the idea that we don't only want to determine who's at risk, but where the patients are on a risk spectrum. So we really know if it's a lifestyle risk, we can send them home for diet and exercise. If there's vulnerable plaque formation, we can get more aggressive. And it's not just you have risk. So the markers in this panel are the F2 isoprostane, general marker of oxidation. High F2 isoprostanes have long-term link to cancer and cardiovascular risk. Now walking towards evidence of vascular disease, albumin-creatinine ratio, looking at endothelial dysfunction and albumin getting through the glomeruli and endothelium in the kidneys into the urine, and hsCRP, which Paul Ritker really has done an amazing job over the past decade and a half, demonstrating its importance in predicting arterial inflammation. Now, based on our work many years ago, we would suggest to you that the hsCRP does not reflect the activity of the atherosclerosis, but rather the presence and perhaps the burden of atheroma in the body. And then ultimately looking at our high-risk patients through myeloperoxidase, looking at vulnerable plaque from inside the vessel lumen back at the endothelium, fissures, erosions, and warming plaque due to erosions from underneath the collagen cap, to the plaque test, which is inside the vessel wall, looking at macrophage activation and, in fact, vulnerable plaque formation from within the wall. Now, we launched the test in 2010. We were very excited to see this work out of Canada by Heslop and colleagues that actually did cardiac catheterization, looked at patients who had mild to moderate disease, non-revascularizable, no need for revascularization. And they followed these patients out for several years and found that, in fact, patients who had higher myeloperoxidase levels, higher likelihood of having the ability or the presence of vulnerable plaque, had a worse mortality than those who actually had a low myeloperoxidase. Further supporting the concept that we put forth in 2.5 years ago with a panel approach and recognizing that no one marker truly helps us fully define our patient. In this study, when they looked at patients who had a low MPO and a low CRP, they actually did incredibly well. If either MPO was high, presence of vulnerable plaque, or the CRP was high, perhaps presence of greater atheroma burden, patients did worse. But if they had a lot of atheroma by a high CRP and a lot of vulnerable plaque with MPO, they did yet worse. So again, demonstrating the concept that no single marker truly defines risk completely. And then our own data, which we've generated in the last 18 months, looking at a preventive cardiology and executive health programs, where you're looking at about 2,700 patients worth of data here. You'll appreciate that looking at vessel wall risk with a plaque greater than 200 is about 5% of the population. Looking at myeloperoxidase or white blood cell risk, looking from inside the lumen back, about 6% of the population is at risk, so overall about 11%. But yet only about 6 of these patients, in fact, exactly 6 of these patients, have a high MPO and a high Lp(a)2 or plaque, suggesting, again, as I talked about during the case studies, the idea that if you have an inflamed vessel wall and your white cells are degranulating in response to that, you really have acute coronary syndrome and you're unlikely to be sitting in an executive health physical. What do we do about some of these patients? And I think if you start looking at your MPOs and plaques, I suspect you'll note that not a lot of folks have both up. But for those folks who do have both up, as mentioned, I think by Alan during the panel discussion, you know, atherosclerosis is not confined to the coronary tree. So these are folks who, if they're not having chest pain in front of you, have some vulnerable plaque that's rupturing somewhere in their body, and really are the ones who warrant pan-vascular assessments, looking at their legs, their bellies, and their neck to find out where the atheroma is truly active. And ultimately, the guidelines have caught up and now recommend that the potential for inflammatory biomarkers to more properly assess hidden cardiovascular risk is appropriate and should be an adjunct to traditional risk factor assessment. The concept being there, again, 50% of the people having infarcts have their lipids to guideline goals, yet they're still having infarcts. And looking for this hidden risk is very reasonable and valuable. To that end, we launched the first Cleveland HeartLab Symposium in September of 2010, and we were pretty excited by that. We're thrilled with your participation this year and the continued success of our symposium, but also our ability to help educate, not just about what we do, but really all of our goal to mitigate cardiovascular risk, define risk, and then what to do about it. We then, in 2011, started a very exciting collaboration with MDVIP, helping launch a new annual wellness panel for them, and this has been a very interesting and exciting collaboration which will be published soon, but I want to give you a little bit of a sense of the data because I think it helps support what a lot of us do. We have over 90,000 annual wellness panels from 2011. It's actually 95,144. Not that Andrea and I have not been through the data many times. Panel approach really identifies patients at risk, and even if you, I hope no one's offended by the concept of the worried well. These are patients who are committed sufficiently to their health to pay out-of-pocket expense to get the concierge care that MDVIP offers. But these are not the Medicaid folks we saw in residency. These aren't folks who really are sick, per se. What's interesting is, the reimbursed risk stratifier that we have is really a classic lipid panel as far as screening. And what we found in this, again, 90-some-odd thousand patients, and one thing when you have 90,000 some odd data points, it's not because you don't have enough data. You got to believe what you find. So, about 28% of the patients, 27% of the patients are at risk if you just look at an LDL greater than 130. So that's kind of the largest catchment there for just typical patients. If you go to LDL under 100, greater than 100, which would be obviously folks who have true risk, now we're talking about 34% of the patients. So about a third of the population has risk in the folks that go to MDVIP. But what's interesting is, only based on the panel we put together with them, only 30% of the people had no markers up, right? So this is obviously not a screening panel, at least by insurance purposes. But yet, 30% of the patients had at least one marker up in this, and this was looking at diabetes, cholesterol risk, inflammation risk, and other things. But looking at multiple markers, 40% of the patients had multiple markers up. If you combine these, now 70% of the population, again, of the quote-unquote worried well, actually have some evidence that their preventive and wellness strategies could be improved, which I think, to me, was very interesting, because I think if you go to most academics, they'll tell you this is unnecessary testing. You're not going to find anything. These folks are okay. And yet, clearly, their strategy is identifying things that we can do based on the literature that will improve the overall health and wellness of their population. And we can recategorize risk, which we find particularly exciting. So if you look at just ApoB and MPO, and there's obviously other markers on this panel, but 70% of the folks had a low MPO and a low ApoB, which is pretty good. 12% roughly had either a high MPO or a high ApoB, but 2.5% of the population, just based on an MPO, the high ApoBs can be reclassified not from risk, but to very high risk, because in fact, not only do they have high particle numbers or high ApoB content, they also are inflamed. And if you take our data based on the ApoB, MPO and plaque, in all likelihood, if we were running plaques on these folks, it would be about 5% of the population we would ultimately reclassify. And really, again, it helps us to determine what to do with that patient on that day or shortly thereafter. Do we just treat with cholesterol-lowering diet and exercise, or do we really need to think about aspirin therapy and things of that nature because they have the evidence of vascular inflammation? So after, with the ongoing collaboration of MDVIP, and Andrea and I, Andrea's the Chief Medical Officer of MDVIP, we're working on to publish these data, and I think you'll find it very interesting, ultimately, because we now can compare different markers and see what are truly redundant markers and things of that nature. I think this is the largest data set that exists. We had our second CHL Symposium in September of 2011, where I think we continued to grow the interest in the concept, but you all gave us some great feedback, and hence the reason we're here, and we have the case studies and things of that nature, because I think it's been a really great interest. In 2012, around May, we launched the IT campaign. IT is for inflammation testing, and we have it, and we're pretty proud of it. And it really is a goal, and I hope you'll see this more and more in your regions and in your offices over the next 6 months. It's really a goal to help get to the practicing clinicians the material not only for themselves but for their patients and for their office, to really help patients understand what this testing's about, where its value is, and why it's important. You know, as we say, it is state-of-the-art cardiovascular risk assessment, and we genuinely believe that to be true, and it can save your life. by identifying risk for stroke and heart attack early. And these kinds of concepts need to be brought forth to the patients so they understand what you guys are trying to do for them and really help you deliver the best care you can. Shortly around when we launched the campaign, we went to TEDMed, which is a very high-end, technologically driven conference in medicine, and we were invited in to actually run inflammatory testing in all the attendees at TEDMed. And it was interesting. This is truly a population of folks who you would think would be relatively low risk. 47% of the patients had abnormal lipids, either a high LDL or a low HDL. 37% of the patients had evidence of atheroma based on a high hsCRP, and 10% of the patients had evidence of vulnerable plaque formation based on a high myeloperoxidase level or plaque. What's also interesting and quite instructive for us is that of the 10% of the folks who had vulnerable plaque, half of them had normal lipids. So again, this is a population of folks who you might have patted on the back and sent home and said, great job, and yet they clearly still have evidence of vascular inflammation and need for risk mitigation. We've done this now for the Functional Medicine Institute meeting and many other meetings, and we're, one day may give out the healthiest meeting award or something, but it's been quite interesting. We launched GAL3 in 2012 to try and help you all and clinicians define patients who are developing cardiac fibrosis in response to hypertension, who really are at risk of diastolic dysfunction, which is a very difficult form of heart failure to treat and far better to prevent than try to treat it. And we launched CoQ10 with the recognition from our research that animals, and then some literature, patients with low ApoA1 may be CoQ10 deficient, and CoQ10 deficiency leads to bigger myocardial infarction and statin intolerance. This work actually, and the link was out of work in my laboratory, where we actually took mice who had no ApoA1 at all, or half the ApoA1 gene, or regular ApoA1, the wild type, and gave them infarcts. We opened their chest and tied off their LAD. And what we were struck to find was that those animals with no ApoA1 had huge myocardial infarctions, in fact so large we could never get them off the ventilator, and yes, there are mice ventilators. But what we were struck to find is the fact that these animals with low ApoA1 levels had incredibly low CoQ10 levels in their heart, and this is true in other muscle beds as well. We've hypothesized that if we replace the ApoA1, the CoQ10, which we did, just by giving it intraperitoneally to the animals, we would normalize the infarcts, and in fact we did. There's a huge controversy about CoQ10 in cardiovascular disease, and in the cardiology community, what has been published several times in the last couple years is this idea: if you measure CoQ10 in a patient with heart failure and it's low, and you supplement them, their ejection fractions actually go up. If these data translate well to humans, which so far they do, you have to reinterpret Framingham, because it may be that low HDLs don't cause increased mortality because you have more myocardial infarctions. It may be that you have bigger myocardial infarctions because you're CoQ10 deficient, because based on these works, it appears that ApoA1 is responsible for the absorption of CoQ10. So we launched CoQ10 to try and help answer those questions in our patients who come and ask us about it, but also, again, to further optimize patients' outcomes. And then we developed an IT management campaign where we said, how do you manage it? And what we did was we said cardiovascular risk can generally be divided into 4 quadrants. There's diabetes and obesity, hypertension, coagulation and genetic risks, and lipids and oxidation. And what we proposed is that what you're really doing by measuring the inflammatory panel is taking a temperature of the vessel wall. If it's cold, it's non-inflamed, things are good. As the risk factors go up and the different tests go up, clearly the risk of an event goes up with it. But if you have somebody, and we further put forth the comment, and it's in the one of the pages of the pamphlet that was released, although it was apparently written by a guy with a K in his name for Marc, not C. We really recognize the fact that defining patient risk and furthering patient wellness is not one visit a year, but an engagement with the patient throughout the year. And I think this is what a lot of our patients are looking for. And, we have put forth and made available a year-long approach to patient assessment. We think there's a lot of advantages to this. It breaks down risk factor assessment and optimization to help patients engage and focus on their care. It simplifies the physician message so that we can really focus on specific risk factors in specific quarters of the year, if it's 4 times a year, specific halves of the year, if it's twice a year. But I think the other thing which we often don't appreciate is it allows our patients to recognize wins, right? If I have hypertension and I'm overweight, if my blood pressure is good and it's hypertension quarter, you can pat me on the back and say, you know what, I'll tell you you're overweight next month. You're doing well. Your hypertension's controlled. Good job, right? Because often what we tell our patients is a litany of the results, and rarely is it all good. And they often leave our office feeling like they're failing. And this really allows us to get our patients wins. And as we talked about yesterday with the heart-brain connection, compliance and feeling good about what they do is really important. So we divided testing up, and we can get you this to greater detail. But there are specific markers, again, for hypertension, looking at GAL3 for fibrosis, NT-proBNP for atrial stretching, a classic CMP, vitamin D, diabetes and obesity, looking at hemoglobin A1C, adiponectin, insulin, things of that nature, lipids and oxidation, looking at the standard lipid panel, small dense LDL, and many of the things that Lynn just talked about, and coagulation and genetics. Again, bringing Lp(a) in there if it's an issue, factor V Leiden, and the things that we may want to check once or update over time to see what the real risk of the patient is. But it's an approach, and we have it available, and we're actually pretty excited about it. So the question is, what's next? And we really do want to continue to move our position forward and what the tools we offer you forward. And I think one of the things that struck me as I put this together is we've spent a lot of time on education and trying to bring an approach to everyone and help explain that. And we have launched some tests, and we're going to launch another now. When in talking to you all and other physicians who are using our products and our approach, people seem very happy with the fact that we have the myeloperoxidase and the Lp(a)2, and we can define high risk actually incredibly well. And we indicate low risk with the F2-isoprostane, but is there something that can help further give granularity to where the patients are in developing risk instead of ultimately having disease and risk? And what we're going to do is add, for the first time, a new marker to our base inflammatory panel, and that marker is going to be oxidized LDL. The reason is, as I said, we're trying to get better granularity earlier in the disease process, and OxLDL has good data in the literature for being a marker of metabolic syndrome, and not just that you have metabolic syndrome, but you're at risk of developing metabolic syndrome in the ensuing handful of years. It's beyond F2-isoprostane, which really does mark lifestyle risk and bad lifestyle with smoking and bad diets, and it's increased oxidized LDL is one step further in the risk process, because now you're actually having protein modification in response to increased oxidation. Oxidized LDL, and I was, my PhD advisor is a gentleman named Guy Chisholm, who arguably in 1978 was the first to show that LDL can become oxidized and toxic. So I've spent a lot of years working in the oxidized LDL space, and it does almost everything that's bad. But listed here are a few of them, which is induced endothelial cell death, part of the injury process again, induced foam cell formation in smooth muscle cells and macrophages. It increases smooth muscle cell coagulation proteins, specifically tissue factor. It induces pro-inflammatory cytokines, sequesters nitric oxide, and induces smooth muscle cell proliferation, and again, a variety of other things. But none of those things on that list are good. It's been shown, whether you have metabolic syndrome or not, again, to predict increased risk of coronary artery disease. So even in folks who have no metabolic syndrome, and the panel on your left is looking at ox-LDL, the panel on your right, or the graph on your right, is looking at the ox-LDL-LDL ratio. But nonetheless, you'll appreciate, even with or without metabolic syndrome, a higher oxidized LDL level is predictive of a higher increased risk of coronary artery disease. And furthermore, again, looking forward in patients who don't have metabolic syndrome at the time of the blood draw, you'll see that the higher the oxidized LDL level here in the upper panel, the higher the risk of developing metabolic syndrome in the ensuing 5 years. And these data are from the Cardia study in about 2,000 patients. LDL did not predict increased risk of developing metabolic syndrome. And this is a study out of India, the Indian atherosclerosis study, again, a couple thousand patients, but you'll appreciate that OXLDL, much greater than HSCRP, predicted the increased risk of developing metabolic syndrome in the ensuing 5 years. So F2-isoprostane is generated from arachidonic acid metabolism, and it's a natural process in the metabolic system, and F2 specifically is instead of prostaglandin is generated when there's a lot of free radicals around, and that is the direction in which arachidonic acid metabolism goes. OXLDL, again, is not part of a metabolic process. It's actual damage to the ApoB protein within LDL, blocking its ability to be absorbed by the, recognized by the LDL receptor. So it's in fact damage instead of metabolism. And it turns out in a recent study published earlier this year, where they looked at chitin glucan as a fiber in the diet to try and lower OXLDL levels, they actually saw a significant decline in OXLDL with what turned out to be about 4.5 grams a day, with no decrease in total cholesterol, and consistent again with the additive nature of OXLDL and F2-isoprostane, no change in F2-isoprostane. So you may be able to clear the modified proteins, but if the system that's generating those modified proteins is still in place, you'll just make more. And so they could, with the chitin glucan, induce a sink for the OXLDL without really changing the oxidation that's driving the process. So this will be our new inflammatory panel. Again, it's F2-isoprostane, looking at lifestyle risk factors. It's looking at OXLDL for a risk of the patient developing metabolic syndrome, but also evidence that that increased oxidation is actually causing protein modification, which ultimately is what leads to the altered biology that leads to disease. HSCRP and albumin-creatinine ratio, and looking at evidence of endothelial dysfunction and evidence of atheroma burden, and then myeloperoxidase and LPPLA2, really looking at evidence of whether that atheroma is actually active and at risk of developing vulnerable plaque and rupture. So once again, this is what we've done in the last 2.5 years, which has been pretty exciting, and we're glad you guys are here with us. Obviously, we're having our 3rd annual symposium now, and we certainly look forward to many more in the future, and we thank you for your participation. Thank you.